Over to Vicente.
All right, thank you very much. Thanks for the introduction, and hopefully everybody can hear me right. It's the first time I've done one of these webinars, so let's see how it goes. I was asked to given a title, image acquisition and analysis, and of course I'm going to try to do my best to give you a good introduction to both areas, which are closely related and interconnected. What I'm going to try to do in the time that we have is I'm going to talk a little bit about image acquisition. I'm going to talk about the basics of image acquisition, talking a little bit about the physics, a little bit about the applications in the cardiac field in particular. So we'll go through the main modalities. Obviously, I'll have to be short on each one of them. But hopefully you'll get an idea of what are the advantages and disadvantages and a bit of a comparison between them and the things that they can do. And then moving on to cardiac image analysis, I thought the best thing here would be to give you a case study. So I'm going to talk about something, a particular application we are working on, which is personalized cardiac modeling. So building personalized models of a specific subject from their images. And I'll talk to you then about the different things that we do in terms of image analysis, the images that we work with, and also the ways in which we process these images to go from the images to a personalized cardiac model. And in that process, hopefully you will also get an idea of what are the things that can or cannot be done automatically in terms of analyzing the images. So we'll start with probably the simplest imaging modality that is out there. That is the use of X-rays. And X-rays are just a form of electromagnetic radiation. As you can see here, this can go all the way from radio waves, which have a very low frequency in comparison with X-rays, which are much higher in frequency, though not as high as gamma rays, which will come into the talk later. Now, because we know that the energy is proportional to the frequency, that means that X-rays are a very high energy. X-ray photons are a very high energy, have a very high energy compared with things like radio waves and visible light or even ultraviolet light. Now, that means that the X-rays are what is called ionizing radiation. These are photons that when they cross through the body, they can produce ions. And this has a lot of harmful effects, from radiation burns all the way to producing cancer and eventually killing the person, right? So I will talk a little bit more about ionizing radiation. Sometimes the doctors just say this gives you a dose of radiation. Okay, as engineers, of course, radio waves are the same exact kind of radiation. It's just that the radiation from X-rays is ionizing. So these very high energy photons can cross most tissues. They are attenuated by things that are very dense. So here, this is the first image that was acquired with X-rays by Professor Röntgen in the late 19th century. And you can see here how the X-rays have been attenuated quite highly by the bones, and they have been attenuated very highly by the ring, which is mostly metallic. So basically what we have is an X-ray source on one side of the person, a detector on the other side of the person, and the detector directly detects how much X-rays are arriving after crossing the body. Now, the applications of this to cardiac medicine, they are not that many in general, because we cannot see. It's inherently a two-dimensional projection that we are getting, so we don't get the three-dimensional detail that we need in something as complex in a three-dimensional sense as is the heart. And the contrast that we get between the soft tissues that constitute the heart, they are not as great, unless we use a trick, which is injecting contrast, which changes the attenuation that the tissue produces to the X-rays. And there is one application in which X-rays are used basically on a daily basis at hospitals, which is angiography. And this is used by using, this is acquired by using a C-arm, which is this thing here, which has, of course, the shape of the letter C. Is on one side we have a detector, on the other side we have an X-ray source, and this can be rotated to take different views of a patient which is lying on the bed. And this can be done in an acute setting. So this might be a patient who has symptoms of a myocardial infarction, and what the doctors will do is they will inject, they will put in a catheter through a vein, and they will reach the vicinity of the heart, and they will inject a contrast and see whether that contrast reaches the parts that it should be reaching, and if not, this might be an indication of a blocked vessel. Let me just show you. So this is, we go back to the previous slide. This is the kind of structure that we want to look at, that we want to analyze, is the structure of the coronaries. So we want to see if any of these coronaries might be blocked. And I'll give you an example so that you get an idea of how these images look like. They are acquired in real time, so they will have put the C-arm in the right position. And this is the video of, what you can see there is a catheter through which they are injecting the contrast agent, and it's filling the vessels gradually. Now, of course, this is made more difficult to understand by the fact that in this case, the patients are breathing normally. So you can see the respiration, and also, of course, the heart is beating. So here, let's take a look at another view. Here is the catheter. So they are going to inject the contrast from this tip, and you will see how the contrast is filling the blood vessels. And this, you can imagine that it's very difficult to get a good three-dimensional understanding, which is what you really want, of these structures, which are, again, three-dimensionally very complex, from just these two-dimensional views. A couple of more examples down here. One of the things that we are doing in the group is we are trying to reconstruct these three-dimensional geometries from multiple views, but this is for another talk. The advantages, some of the advantages, that actually the resolution is very good, both temporal and spatial resolution. It is very cheap. It's used every day at the hospital, so it's available basically everywhere, and it's very fast. Some of the limitations that I've already mentioned about the loss of 3D information, poor contrast, in particularly in the heart, and the presence of ionizing radiation. So these X-rays in general are dangerous, though the amount of X-rays that are given in one of these explorations is not particularly worrying. It might be actually more of a worry to the professionals, the health professionals that are around the table at that time, that are also going to get some of the residual X-rays, and that are doing these interventions on a daily basis. Okay, so one of the main problems with X-rays then is that we are only seeing a projection of the whole body as the X-rays go across the body, right? So if we could just have a source of X-rays that produces a very thin ray, like a pencil beam, then in this very simplified toy example that I'm putting here, we are trying to divide a slice of the body into 4 regions. And we are going to try to quantify the attenuation of each one of these regions here, right? So if we had 4 sources and 4 detectors, each one of them producing one of these pencil beams, so we would have this ray here, which is attenuated by beta 11 plus beta 12, this one here, beta 21, beta 22, this one here, we can again measure the attenuation, and this one here, we would end up with a system of equations with four equations and 4 unknowns. So in principle, we should be able to resolve spatially what is the attenuation for each one of these 4 regions. And if you can, you think about this as a big image with each one of these regions being a pixel, we should be able to get an image of attenuation, showing the attenuations on one slice of the body. And if we do it for a number of adjacent slices, we would end up with a good 3-dimensional reconstruction of what is the attenuation of different things. And here we can see, well, this is across the abdomen, and we can see mostly is the spine. Yeah, in reality, it's not as easy as solving this system of equations, but it's not terribly complicated either. This is the first generation of CT scanners, the way they worked. So you would have rotating source and a ring of detectors around it. The source would produce a number of pencil beams. They would be picked up by the detectors on the other side, and then you would have these would rotate, and you would have other detectors that receive the attenuation and so on. And if you do this enough times, you will have enough pieces of data that allow you to reconstruct the attenuation of different pieces of this slice with good resolution. More recently, spiral CT was developed, in which, in this case, this is just one of the ways in which these rudimentary first scanning methods were improved. In this case, in spiral CT, the patient is actually moving through the scanner while the ring is the detectors, the ring is rotating, the X-ray tube is rotating. So we get a spiral acquisition, and we can use that to reconstruct using the appropriate mathematical equations, which I'm not going to talk about today. You can use this to reconstruct a three-dimensional picture of the body in terms of just attenuation of X-rays, right, which is possibly the main limitation here. This is a sample, one CT scan, and this is one sample image. There's nothing in particular about this image. I've just chosen a sample one that was available online, but you can see that there is very good contrast between places where there is blood and the myocardial tissue. We cannot tell too much about differences within the myocardial tissue, which we will talk about a little bit later. But if we want to get a reconstruction of the chambers of the heart in 3D, this is possibly the best method that we can use. It has a number of advantages. So it has very good resolution. It has widespread availability, not as much as a plain X-ray machine, but basically every medium-sized hospital will have a CT scanner. It's very easy to use, so there are not many parameters that one needs to change and play with when one is acquiring a CT scan. We can use contrast agents can be used. This is an advantage, but it might also be considered a limitation because they have to be used for a number of things. Temporal resolution is not as good as spatial. Possibly the main limitations are that there is limited functional and tissue composition information compared with other modalities. So it gives you very good anatomy, but less in terms of tissue composition and function. And the presence of ionizing radiation has been a concern, though in recent years, the amount of radiation that CT scans require has gone down a lot, and low dose CT scans now give very good quality images. So it is becoming much less of an issue, but it's still something that needs to be thought about in a number of situations, like, for example, requiring repeated scans multiple times, or in terms of when children are scanned, and other situations. Moving on, so with the things that I have talked about up to now have been based on X-rays, either just the X-ray C-arm imaging, or the CT scan, which is a 3D reconstruction, but it's still based on X-ray. Ultrasound is probably the most commonly used imaging modality when looking at the heart. It's also called echography, or in the case of the heart, echocardiography. And this does not use electromagnetic waves. This doesn't use electromagnetic radiation. It uses sound just as at a very high frequency. So it's a mechanical wave, it's a mechanical vibration, right? In that way, it's similar to what bats use to check their surroundings, right? So they emit sound and also sound because the frequency is above what is audible by the human ear, and then they wait for the echo. And depending on how long it takes for the echo to return, that is how far the obstacle is. If we know the speed of sound, which we know in tissue, then directly from that time, we can detect, we can calculate how far the obstacle that has returned the echo is, that which helps us reconstruct images. It's also similar to the system that boats use to detect whether a school of fish under the water and at what depth by emitting sound or ultrasound and waiting for the echoes to return. Now this is a basic scheme of how it works. So we have an electrical pulse, goes to a transducer. The transducer transforms the electrical pulse into the mechanical pulse. So that's the ultrasound. And this mechanical pulse goes into the body, and we can represent the inside of the body as a number of reflectors. Some of them are very strong reflectors. They reflect most of the sound that is arriving to them. Some others are weaker reflectors. All of them will reflect part of the signal and let some of the signal, an attenuated version of the signal, go through. More and more attenuated depending on what the reflectors are. Now we can record the signal as it arrives back at the transducer. This is the signal, and in this case, for this simplified representation, it has 3 echoes, one big one for the big reflector and 2 smaller ones for the other, for the weaker ones, right? So this gives us like a line representing what is in the tissue inside of that line, right? So if we represented this with intensity values on a screen, this would be kind of gray. This one here would be a white spot, white thick spot, and this would be another gray spot, and the bottom line, that would be a black region. So that creates a line. If we do that for many different lines with this two-dimensional transducer, which can produce the ultrasound beams at different angles, then we can take all these lines together and form an image. This is basically as simple as it is. Of course, there are a number of signal processing. There is a lot of um, tricks and tools to improve the quality of the image, but the basics are just like this. And because this is just ultrasound at the powers that it is applied to the human body, so clinically, it has no harmful effects that have been measured up to now. Now, this would be a two-dimensional scan, and still the majority of probes and ultrasound systems that are used in the clinic are still two-dimensional. As I said, this is the most widely used imaging modality in cardiac medicine. And in a great majority of cases, it is done in 2D. There are now there have been actually for a few years, three-dimensional probes that can be used, and that will give you, it's just the same thing, but basically these lines are transmitted in 3 dimensions. So instead of forming here this kind of triangle, they form a triangular prism. So these are just 2 examples of images, right? They are not particularly good quality. I have not chosen them because of that. They are just 2 slices through a 3-dimensional acquisition. So it gives you a quality that is a little bit better than with plain 2-dimensional scans. But I wanted to show you just to get an idea of how the images look like, right? So they are always represented in this way. This will be the apex. So it's kind of the wrong way around. We expect to see the heart. So this is the apex is up here. This is the left ventricle, and we see the valves opening and closing, which gives you an idea of how good temporal resolution we can get to it with it, right? And here we would be seeing the left atrium. On this side, there is the right ventricle, which is partly outside of the picture, outside of field of view. I also wanted to show you this because the probe is located, is placed on top of the skin. So it has to be placed in a way that it reaches the heart, but it does it without going across the ribs, because the ribs will not let the ultrasound signal go through. They will reflect it to a great extent. So there are a number of windows that have been defined. The most common one is the apical window, which approaches the heart from the apex. And there is also the parasternal window next to the sternum between two ribs. And this gives us a kind of sideways, if you forgive me for not using the proper clinical terms, sideways look at the heart. So this will be the left ventricle here, and here you see again the valve opening and closing in real time. So this is acquired in real time. And one of the interesting things about this is the presence of speckles. So speckles are these, if I can turn this on again, I think this one doesn't want to move. Okay, so you see the little dots that appear that form this textured image. They are called the speckles, and they are supposed to move together with the tissue. So if we can identify one of these speckles here and we follow it as the heart beats, then we can estimate the formation of the heart also in real time. And there are systems that use this speckle tracking to estimate the formation. Apart from that, we can get the delineation of the cavities is a bit challenging because the quality of the surfaces is not as great as in other modalities, certainly not as good as in the CT image that we saw before. So the interpretation of these images is subject to, first of all, the clinicians, as trained clinician, needs to have some manual input, though a lot of progress has been made in automated tracing, but it's still mostly a manual process in the clinic. And also there is significant inter-observer variability in the measuring of parameters from these images. So some of the advantages, there is very low cost. There are no health risks as that have been found up to now. There is limited tissue and functional characterization. I hesitate to put here noisy images because it's not really this kind of speckly pattern is actually something that can provide information, but it's true that the edges are not perfectly clear and the interpretation can be subjective. And the acquisition also requires experienced operators because it has to be placed at the right position. It can be used as speckle tracking to characterize motion, and also by using the Doppler effect, which, as you probably know, changes the frequency of the signal if it comes from a moving object, depending on whether the object is moving towards the transducer or away from the transducer, it will change the frequency, and that can be measured to give us information about motion, but only in the direction of the ultrasound beam. We move on to magnetic resonance imaging. Now, the physics of magnetic resonance imaging are too complicated for me to try to explain them in a couple of minutes here. But basically, the patient is placed on a high field, constant magnetic field, right? Which is this B here. This aligns certain nuclei in the same direction. And the nuclei that we are mostly looking at are hydrogen, because hydrogen nuclei is where there is water, there are hydrogen nuclei. They are everywhere in the body. They are very abundant, right? So then radio frequency waves are applied that change the magnetization vector, and that the return of the magnetization vector to their original position is what is mostly measured. Now, this is related to the structure of the tissue, so it can detect changes between different types of soft tissue. They have to be spatially located, and to spatially locate them, again, this is a bit complicated for such a short presentation, but it's basically done by changing the field in a gradient. So that's why in MRI they call about gradient in sequences. There are many different types in which this excitation and relaxation can be applied, and they have different advantages and they can measure different things. So this is all a field of research on its own. But well, having give you this crash course on MRI, here is what we get on the other side. Okay, this is one slice of a beating heart. Here we can see it's a what we call a short axis slice because of the orientation of the slice. Here we can see a beating left ventricle. We can see the contraction pattern, and here we can see a beating right ventricle. We can see the tissues around it. So we get this is done. This is what is called cine MRI for the word for movie. So we acquire this one slice over one cardiac cycle. During this time, which takes a number of seconds, the patient has to hold their breath. So you will see that the lung here is you don't have breathing motion as we had in these angiographies early on, right? So because the contrast is good, the reproducibility of the contour delineation is also good. And MRI, cine MRI, is usually considered the gold standard when calculating things like the volume of the cavity or the ejection fraction, which is a ratio between the volumes of the cavity. Now, because each one of these slices has to be acquired while the patient is holding their breath, only a certain number of slices can be acquired, right? So if each one of them is going to take a few seconds, then the patient will have to breathe again, hold their breath again. It's going to take maybe 1 minute per slice at least, right? So generally, the protocol that is followed is the acquisition of a number of short axis slices, like the ones here which are parallel, that cover the whole of the left and right ventricles from the apex all the way to the atrioventricular plane. And then, because that doesn't give very good definition of the places where there is a strong curvature of the wall, like at the base and at the apex, together with this stack of short axes, two or more long axis slices, which are approximately perpendicular to the short axis, are also acquired, which ends up giving us something like this. This collection of slices, some of them parallel and some of them not parallel, from which we may want to construct a three-dimensional geometrical reconstruction. And I'll talk about that a little bit later. Because each one of these slices have been acquired at a different breath hold, it's impossible to assure that the patient will have hold their breath at exactly the same lung volume. So the heart is going to be at a slightly different position in the chest, depending on how good the patient was at holding their breath at the same volume, or how good the person who was taking the scan, the radiographer, was at giving them instructions so that they could hold their breath always at the same level, right? But in general, we expect these slices to give us slightly misaligned positions of the heart. Now, the main advantage of MRI is that it can give us multiple structure and function characterization. So this is the cine scan, and these are the short axis slices that I told you. They are parallel, they form a stack all the way from the base to the apex here. And then here there are two standard long axis acquisition, one of them showing the left ventricle and the right ventricle, and the other one here is just showing us the left ventricle. This one is approximately perpendicular to this one, sometimes called a two-chamber and a four-chamber view. So this gives us the anatomy, and it can also be used to estimate contraction by following. We can apply image analysis procedures to this to calculate motion at different points. There are also ways in which we can characterize the tissue. For example, one of the most common one is late gadolinium enhancement. A contrast, gadolinium-based contrast is injected, and a little bit later, an image is acquired, and places where the gadolinium is still present in the myocardium, like here, are indicators that the tissue is not healthy there, and it's likely to be an infarction. So here we are detecting an infarcted area. We can also do this without contrast by using more recently developed modality, MRI sequence that is called T1 mapping, that gives us direct values of a particular property of the tissue, that is the T1 value. And here again, we see an area where the T1 is abnormal. We can even get things like fiber orientation by looking at diffusion of the water in different directions. We can see the angle in which the cardiomyocytes are aligned. And we can also get motion in a number of ways. This one is called MRI tagging. So what is done here is that a magnetic pattern is imposed on the tissue, and then it is followed over the heartbeat. And you can see here the crossing of the lines here, how it moves, and that gives us a direct quantification of how the heart is beating. There are also other, there are several different ways in which we can encode displacement or velocity using MRI. Again, using multiple different sequences. So we can also estimate motion, and we can do it in 3D in principle. So there are a number of advantages. It has very good contrast. It gives you structure and function in a single modality characterization. Some people have tried to sell MRI as a one-stop shop for cardiac assessment. The radiation is not ionizing, so in principle it's not harmful, unless the person has a ferromagnetic implant, in which case they shouldn't be close to a very high-intensity magnet. It can be difficult to operate, particularly when you're looking at more complicated sequences, and it's much more expensive than some of the other modalities that we've seen up to now. And the last thing that I wanted to introduce in terms of imaging modalities is nuclear medicine imaging. Nuclear medicine works by injecting a tracer that's a radioactive chemical, right? It's injected into the body of the subject, and then the results of the disintegration of that radioactive atom are picked up either by a gamma camera, as here, or by smaller detectors, as in the case of here. So this one is called PET, positron emission tomography. Positron emission tomography works by capturing two photons that are produced that travel in opposite directions, that occur with the disintegration of one of these radioactive atoms, and SPECT directly captures the gamma radiation that is produced by those atoms. If you remember the plot that I put at the start, this gamma radiation has a frequency, thus an energy that is even higher than X-rays. So it is a very strongly ionizing radiation, and is something that is potentially can be very harmful to the patient. The other problem with these radioactive tracers is that they tend to disintegrate quite rapidly. So some of them have a half-life of only a few minutes, so they have to be produced close to the machine, to the scanner. The acquisition is a little bit like what we saw in CT. There are a number of acquisitions, and then they are reconstructed to produce 2D or 3D map. Because I will show you this, because they don't give very good anatomical. This is obviously brain images, because the anatomical information that they give is not very good. They tend to come combined with CT. So in a single machine, PET CT or SPECT CT, so we can get also the anatomy well defined. And these days also there are PET MRI machines, so combined with MRI. And this is an application on the heart. So we can, depending, the great thing about these modalities is that depending on the tracer, we can follow the tracer, and these tracers have been manufactured, can be designed and manufactured to participate in some part of the metabolism of the person. So they can give us a purely functional snapshot of what is going on in the heart. Here, the main application is perfusion. So they're looking at where blood is going in the myocardium and seeing if there are places where blood is not quite reaching. This is a number of subjects, places where blood might not be reaching the myocardium. So perfusion defects, and this can help us then determine what is the best treatment plan. So it can provide functional information, but it's dangerous because of the presence of ionizing radiation. It is very expensive. There is this problem that I mentioned about the short half-life of tracers, and on their own they provide poor anatomical information. But if they are combined with another modality, then they can give us both sides of the coin. So I have presented a number of the main imaging modalities that are used to image the heart. And in this last part of the talk, I wanted to explain one example in which we are taking information from images and we are applying a number of analysis steps in order to get where we want, which is the production of accurate computer models for cardiac images. So this is what we want to get, right? This is what we are getting. So we want to get an accurate three-dimensional reconstruction of the heart and also of the contours of the patient's skin, so that we can then simulate the electrical activity in the heart from simulated electrodes, from simulated sites, and then we can collect that voltage on simulated electrodes that are placed on top of the body as ECG leads would be placed, right? And this is the signal that we are collecting. And then we can use this to do things like, for example, what happens if a patient has a different shape of the heart? What is the result going to be on the ECG? What happens if the patient has a certain infarcted area? What is going to happen with the ECG? What happens if we give this patient some drugs? How is that going to change the ECG? Or the other way around, we are acquiring an ECG from the patient. Is this compatible with the patient having a myocardial infarction in the area that we think the patient has, right? There's a lot of things that we can do if these models are accurate and reliable. So we are doing it from MRI images. So we have a collection of MRI images, and we want to get from here to this three-dimensional representation, and it's challenging. It's challenging in a number of ways. We have to extract the surfaces from the images, and we don't want to have to contour them by hand every single time. We want to do it automatically. So this is what is called segmentation, and it has been one of the main areas of medical image analysis for many, many years. It's basically the separation of the image into anatomically or functionally relevant units. And we can do that these days. Well, if we get that, it's not just that we can create these models. We can also calculate parameters that are of clinical relevance directly in an automated way. We can do that these days thanks to deep learning. This has uh, caused a massive difference in what we can do with these images automatically. In this case, the results that I showed you in the previous slide, they were obtained by Hao Shu, who is one of the PhD students in our group, by using this architecture that is called a UNet. So these are a number of convolutions that are applied that are automatically trained in a training stage. And then there are a number of deconvolutions on the other side. There are convolutions and there is downsampling of the image when we go from one level to the next. On the other side, there is upsampling and again these deconvolutions, and we end up with an image which has the same size as the original image, but in this case it's segmented. And we can train this if we have a big enough data set of segmented data sets of segmented images. We can train this from scratch, and we are getting excellent results as many other groups around the world. Of course, there's still a lot to be improved here, but we can use this as a pretty good baseline. Now, because our scans, as I said, consist in a number of slices, some of them parallel, some of them are not, we can segment each one of them separately, but what we want to do in the end is build this three-dimensional model. So we have the problem that I mentioned earlier, that because each one of these slices has been acquired on a separate breath hold, the volume of the lung was not exactly the same on each one of the slices. So there is a certain misalignment between the images that are acquired on each one of them. And we have also been looking at image analysis way to compensate for this misalignment. Now, the way we did this originally was by using what is called in image analysis registration. Registration tries to find the best relative positioning of different images, and by best relative positioning, I mean in a mathematical term, the positioning that maximizes some kind of alignment metric, right? And in this case, this was done by Ernesto by Ben Willard, another one of our PhD students, and was supervised by Ernesto Zacur in this case. So what what we are doing here is we are taking slices that intersect, and we are just moving them and rotating and translating them until we find the location in which their intersection matches best. The intersection line, it matches best. And we were trying different ways to quantify this metric. And we found that with some of the more advanced metrics that we were trying, the results, the alignment was improved in a very substantial amount. So we go from something like this, where the slices are very clearly misaligned, to something like this, where we can get a consistent three-dimensional representation of the heart by using this. This is what is called, as I said, image registration. And image segmentation and image registration have been the two main fields of biomedical image analysis for a very long time. Right? We have evolved this to something a little bit more sophisticated, in which we are registering the slices or aligning the slices and segmenting, producing the three-dimensional mesh in a simultaneous way by using an iterative method. And we use that by looking at patches where the mesh intersects with the slices, and looking at deformation of these patches and applying this deformation to the meshes. And we get results like this. Okay, now this will allow us to reconstruct the three-dimensional surfaces from the cine MRIs. But as I said before, with MRI, we can get also tissue composition and other things, right? So if we want to introduce here the possible presence of an infected area, say from these late gadolinium enhanced images that I mentioned before, we need to take the slices that we get from cine MRI and register them with the slices that we get from late gadolinium enhancement, right? And if we try to do that directly, it's difficult because it's difficult to mathematically define when they are well aligned because the images are too different. But if we convert them into some intermediate representation like we are doing here, this is a phase, local phase analysis, then the images are close enough in terms of intensities that we can just look at the relative differences of intensity between them, and that's enough to provide us a good registration. So that is what we do, and we can do that also for looking at changes that occur for the same patient, for the same subject at different times, like with 6 months follow-up, for example, in the case of infected patients. Okay, and the final bit, I said, we don't just want the heart, we also want the the surface of the body. Now, because the acquisitions in cardiac MRI, they do not have as an aim the reconstruction of the skin, right? So we have to make do with the information that we get as kind of a side contribution of the cardiac images, right? So from these images we can get a number of contours, but it's only a small number of contours, like these ones here in green, red, and blue. It's only a small number of contours, and we cannot just fit a mesh to those contours. We would never get a good representation of the human body. So what we need is to start with a representation of a human body that we can parameterize, is parameterized, and then find the parameters within that distribution that best fit the contours for that specific person. So what we need is a statistical model. And this is what we have here, right? See, this is the statistical model in which we are changing one of the parameters, and this changing one parameter might make a patient taller or shorter or thicker, or a number of things can change, right? Or even changing like the position